Good morning, everybody who is attending my lecture, and I think it will prove to be very helpful to you in your career if you attend to my lectures. Now, today we are going to discuss the management of anesthesia, very vital part in the diabetes mellitus and anesthesiology. In order to limit the duration of pre-operative fasting, it is generally recommended to post as the first case in the day. The choice of drug for induction and maintenance of anesthesia is less important than monitoring of the blood glucose concentration and management of potential physiological derangements associated with diabetes. Probably the most important considerations in the choice of appropriate anesthetic technique is the avoidance of cardiovascular and renal neurological end organ damage, and anesthetic technique associated with little post-operative nausea and vomiting is highly desirable. Consideration should be taken for potential difficulty with endotracheal intubation, increased risk of aspiration, cardiovascular disease, renal insufficiency, and autonomic cardiovascular disease, renal insufficiency and autonomic neuropathy. Induced hypotension is relatively contraindicated in view of the likelihood of cerebrovascular insufficiency and the potential risk of spinal cord infarction. Preoperative renal insufficiency will require the adequate hydration, maintenance of renal perfusion, and consideration of invasive monitoring. However, urinary catheterization is best avoided if possible in minor cases because of the risk of urinary tract infection. The signs of hypoglycemia, with its risk of cerebral damage, should be continuously sought. Although sweating, pallor, and tachycardia may be obtended by the general anesthesia or have other etiologies, regular blood glucose estimations are therefore essential. The infusion of lactate-containing solutions have been condemned because of their glucogenic effect, worsening the glycemic control and the exacerbation of any pre-existing acidosis. Blood also contains lactate derived from the anaerobic metabolism during storage, and insulin requirements may increase substantially after large transfusions. The anesthesiologist has two approaches available to modify the neuroendocrine response to surgery. Regional anesthesia technique such central neuraxial blockade reduce the response to surgery, but are relatively ineffective in the upper abdominal and thoracic surgery. Alternatively, the use of high specific the high dose opioid anesthesia reduce the hyperglycemic response. Any benefits of the anesthetic techniques chosen must be weighed against the possible complication of hypotension and ventilation, depression. Now we come to the end of my lecture series on diabetes mellitus and anesthesia, and more informations I will discuss with you in my next topic, which will shortly follow. Thank you.